Good afternoon. I'd like to welcome members to this afternoon's in-person meeting of the Rutland Health and Wellbeing Board, and to members and colleagues of the public, colleagues and members of the public who are listening in via Teams. We have another busy agenda for today's meeting, so firstly to practical matters. Not expecting a test of the building's fire alarm this afternoon, so if it does go off, please exit the building by the nearest exit, and the rallying point is at the rear of the car park. I would like to remind attendees that they need to raise their hand if they wish to speak. For the benefit of the webcast and the recording, they need to switch on their microphone when addressing an item and switch it off when they're speaking. I'll refer to the scrutiny officer from Democratic Services if I need to record a vote or for any procedural matters. Right, thank you. First, moving on to apologies. Have we received any, Jane?
Thank you, Chair. Apologies have been received from Deborah Stewart, Emma Jefferson, Councillor Tim Smith, Simon Pizzey, Mitch Harper, Susan Louise Hope and Sammy LaCour. We've also received apologies from David Williams, but he has sent Glyn Edwards as his representative.
Thank you. The record of the meeting, this is to confirm the minutes of the Rutland Health and Wellbeing Board meeting held on the 17th of June 2025 are an accurate record. Are there any amendments to the minutes held on the 17th of June? Anyone got any comments? No? So all those in favour, oops, no, yes, all those in favour. Did they second me?
I won't.
All those in favour, please raise your hand. Anyone against? Any abstentions? No. Just Glyn, who can't. Thank you. The minutes are confirmed. There are no actions arising from the previous meeting, so we'll move on to the next item. Are there any declarations of interest to be declared this afternoon? No, thank you very much. Jane, have we received any petitions, deputations or questions?
None received, Chair.
Thank you, Jane. And do we have any questions from members?
None received, Chair.
And do we have any notices of motion from members?
None received, Chair.
Right, we can move swiftly on to item number 8. This is the Pharmaceutical Needs Assessment. It's report number 91/2025 from Mike Sands, Director of Public Health, and Amy Chamberlain, Senior Public Health Analyst. So Mike is going to introduce the report. Thank you, Mike.
Yeah, thank you, Chair. Just to remind Board, I think we need to produce the final Pharmaceutical Needs Assessment, or the final copy of it, by the 1st of October to meet statutory deadlines. So the report that comes to you is the final draft, if you like, which we're looking for approval of the Board to go and publish it. With that work, as you know, it's a product of the Health and Wellbeing Board that's been taken forward by the P&A reference group on our behalf. So I've got Paul and Amy, and I think we've got Hannah online. So I'm going to look to Amy just to take us through. It's probably the results of the consultation, the changes made from the initial draft, just to highlight the key changes to the board, and then we can hopefully get approval. So all yours, Amy.
Perfect, thank you. I'll just share my screen. I've got a few slides. Is that coming through okay?
Yes, it has, Amy. Thank you.
Perfect, thank you. So yeah, as Mike said, at the virtual board meeting held for the Pharmaceutical Needs Assessment in May, the board considered and approved the pre-consultation draft for the 60-day statutory consultation.
Amy, sorry to interrupt. We can't hear you very well. We're just going to see if we can fiddle with the volume. Just hold it there a moment, please.
No worries, thank you.
Could you just say something to us now, please, and we can test you?
Hello, can you hear me?
I think that's fine. It's not that clear, so you may have. Could you move towards the mic and speak? That's it, and speak quite clearly because you're a bit muffled, but you're on full. Thank you.
Perfect, thank you. So yeah, since the meeting in May, we have been out for consultation, and the final draft of the Rutland Pharmaceutical Needs Assessment for 2025 is included in the agenda reports pack. Most of the document has stayed the same since the previous board meeting, so I'm not going to go through all of that now. I'll just run through a quick reminder of what the P&A is and the most significant changes since the last meeting. So this is essentially an overview of the statutory consultation results, the conclusions and the key recommendations. So just a quick reminder, the purpose of the Pharmaceutical Needs Assessment, or the P&A, is to identify the pharmaceutical services that are currently available and to assess the current and future need for services. This is to inform planning and commissioning and to inform decision making in response to new pharmacy applications made to the Integrated Care Board. The P&A document includes sections on pharmaceutical services and contracts, health needs of the population of Rutland, current pharmaceutical provision, consultation results, projected future needs, gaps, recommendations and conclusions. So the 60-day statutory consultation of the P&A ran from the 9th of June to the 11th of August. The full list of statutory consultees were notified and asked to submit their views about the contents of the P&A as part of the consultation. The full list of statutory consultees is available in the main document, but the list includes organisations like the Local Pharmaceutical Committee, local pharmacies and dispensing doctors, Health Watch, NHS England and neighbouring health and wellbeing boards. A questionnaire was developed to gain feedback on the draft P&A, and this was distributed to the statutory consultees. The Leicester, Leicestershire and Rutland Integrated Care Board also included an article on the consultation in their newsletter, and the link was posted on local LinkedIn pages. Overall, we received 6 responses to the Rutland statutory consultation, 5 of which were made through the questionnaire, and then we also received an official response in writing by the Leicester, Leicestershire and Rutland Integrated Care Board. We also received detailed comments provided by members of the LLR P&A reference group, many of which did represent statutory consultees. Overall, the statutory consultation highlighted general support for the contents, the conclusions and the recommendations of the Rutland P&A. So all respondents agreed that the purpose of the P&A is clearly explained in the draft. Most agreed that the draft adequately reflected the current pharmaceutical provision in Rutland and that there were no pharmaceutical services reported there were no services reported that are currently provided in Rutland that had not been highlighted within the P&A. Majority of respondents agreed that the needs of the population of Rutland had been adequately reflected in the P&A. 20% neither agreed or disagreed with this statement. One respondent did feel that transport and parking, particularly for disabled people and people with disabilities, had not been addressed in the P&A. This comment has since been addressed in the recommendations of the document. When respondents were asked whether there were any gaps or issues in the pharmaceutical provision in Rutland that had not been reflected in the P&A, 20% of respondents responded yes. The suggested gap was that the P&A did not provide enough detail as to how Rutland residents can contact alternative contractors where there are no pharmacies in Rutland providing specific advanced pharmacy services. We had noted in the P&A alternative sources of the provision, and it was deemed that this was sufficient for the scope of the P&A. Majority of respondents tended to agree that the conclusions and recommendations in the draft P&A were accurate, and 80% of respondents also agreed that the P&A had enough information to help plan future pharmacy services and to support pharmacies and dispensing applicants contractors. In terms of the response from the Leicester, Leicestershire and Rutland Integrated Care Board, they noted that accessibility from both a geographical and opening hours perspective continues to be a strength. They were pleased that no significant gaps in the provision of essential pharmaceutical services had been identified in Rutland, and they also highlighted 5 priorities. So these were service integration and expansion, innovation, digital enablement, promotion of public health and planning for growth. So overall, the response from the ICB was supportive of the conclusions and recommendations in the 2025 Rutland P&A, and the full ICB response has been included as an appendix to the board paper for further detail. So the conclusions haven't changed since the meeting in May, but as a quick reminder, subject to the importance of continued voluntary community and public transport. No gaps have been identified in the provision of essential, advanced, enhanced or locally commissioned services across the Health and Wellbeing Board area. In terms of the conclusions, the current needs of the Rutland population are being met by pharmacies. There are differences in the local provision across the county, and it may be that residents in some areas have to travel further to access a particular service or outside of normal working hours. The level of activity provided has increased across most of the advanced services where activity was provided. But overall, Rutland residents are generally happy with the pharmacy services that they receive. In terms of the recommendations of the P&A, some of the recommendations are similar to those included in the previous P&A. So I won't go through each of these, but they are included in the main document. The recommendations are aimed at Leicester, Leicestershire and Rutland Integrated Care Board, and where relevant, Rutland County Council and NHS England. And the key recommendations added to the 2025 P&A include to continue to monitor the impact of the closure of Pickford's Pharmacy in Oakham, which is highlighted in the report. And this is to ensure that the remaining pharmacies can meet any change in demand for services, particularly with the projected growth in the population that's been reported. Another recommendation is to consider the opportunities that independent prescribing may offer to service delivery and look to integrate independent prescribing where appropriate. To keep under review the timely access to medications and to promote the wider use of private consultation rooms. To encourage pharmacies to offer locally commissioned services in relation to local need. To consider the access needs for those with disabilities, including the availability of accessible transport and parking facilities. To monitor current and future housing development plans and to consider pharmacy provision within these areas. That's to ensure that future increases in demand can be met with adequate provision. Another recommendation is to consider and address inequalities in digital literacy to ensure access to services for all residents, and to continue to review workforce availability, and particularly where this is impacted by the availability of high quality foundation training posts across LLR. Some other recommendations under the promotion of health and healthcare management include to continue to consider the opportunities to include and develop the role of pharmacies in commissioning strategies. This is to provide services which deflect work out of the primary care general practice and also urgent care services. To improve the available pharmaceutical data sets, to ensure continued improvements in digital developments, including in communications between GPs, pharmacies and residents, particularly in relation to prescriptions and medicines delivery and also availability. Under the implications of community pharmacy policy, some of the recommendations include to review evidence of the impact of the recent policy and funding changes on services. To review and manage the impact of increasing demand for pharmacy services, so particularly with the Pharmacy First and the blood pressure or hypertension case finding services. To review and manage the impact of advances in online and digital services on the community pharmacies themselves. And then finally to consider periodic reviews of the recommendations and progress on these to present to the Health and Wellbeing Board. So that's kind of the update I have.
Thank you very much, Amy. Pass you back to Mike. Do you want to say anything? I've got a couple of comments.
Yeah, I've more got a couple of questions for Amy, so should we open up for questions and I'll do that as we go.
Right, Amy, I've got some questions for you, and it may be more Mike, but my first is, there's a seat here. Sorry, just a comment. We had 6 responses. Is that adequate enough to actually come up with these statistical responses? And what are those compared to L and L?
So we had 6 responses to the official 5 responses to the official questionnaire and then 1 written response from the ICB. But I think it is sufficient, as we've also had input throughout the PNA process from a lot of the statutory consultee representatives through the LLR PNA reference group. So a lot of representatives from the statutory consultees have been feeding into the document kind of as we've built it and gone along the process.
Yeah, I was going to ask the same thing, Amy, but it's variation on a theme, which is we've only got 6 responses. Okay, we're not going to get a huge number of responses, but I couldn't see, and forgive me if it's in there. I know you talked about the LPC being one responder in the ICB. So the other way of asking the question is, it ends up being a little bit kind of marking your own homework, but if you're not going to get huge numbers, you want the right people to have responded. So it's a question of, are the people who are going to use it, NHS England and the ICB, content with the recommendations, that they make sense to them and that they can take them forward? And then I suppose the other one is, including the LPC, is there a sufficient quality of response to be able to go, yeah, okay, we've sense checked this with people who know something about this and they agree with the content as well. So there's probably 2 questions, which I'll look to you to. It's a bit unfair to lump them both with you. There's Diane's sense of numerically, does it kind of stack up with others? But then I suppose I was more thinking, we haven't got the numbers. Quality-wise, though, to the professionals who've been around the table, and as you say, have been involved all the way through, does it pass muster? Does it make sense to them in terms of what we're saying?
As far as we're aware, yeah. As I say, we got a detailed written response from the ICB and they supported the conclusions, contents and recommendations of the document. We have had representatives from the LPC in the PNA reference group throughout the process, and we haven't had comment from them that they're unhappy with the contents. And we have had in previous drafts, they did provide detailed comments on the document to help us improve the contents.
Then my other one was, when we talk about the monitoring of the impact of Pickford's, the closure of Pickford's, and I think there's a number of other bits of monitoring, whose job is that? Are we seeing it as being our job as the Health and Wellbeing Board, or is that it's still a recommendation for the commissioners of pharmacy services to do all that kind of monitoring?
Question. I think it would fall to the ICB. Sorry, Paul, do you want to come in?
I'll come in after you finish to give an ICB NHS perspective on that.
Yeah. So I think it would fall to the ICB to monitor that. I will say that throughout the document, I have made reference to the projected impact of the closure of Pickford's in terms of its location and the opening hours and the availability of services. And it is the case that there is another pharmacy located on the same street as Pickford's pharmacy that will remain open and offers a similar range of advanced services and has opening times which cover the opening times of the previously closed Pickford's pharmacy.
Yeah, so if I provide the NHS perspective on the monitoring of this, I would perceive it without a doubt to lie in the responsibility of the commissioners for community pharmacy services, which the ICB delegate to the East Midlands Primary Care Team, who commission pharmacy across the East Midlands, the 5 ICBs. But we do work closely with them to analyse trends in both sort of quantitatively around service performance numbers and also qualitatively around feedback we get from both patients through sort of formal and informal complaints and passed on by GP practices, and then also directly made to the ICB as well. So it's certainly within the scope of the ICB's role to monitor any impact of pharmacy closures.
Cheers, Paul, if you could just respond. I think that would be really useful. One of the things I was going to say is I sort of looked to you to make that link with the East Midlands pharmacy team. I guess I feel, being honest, when we've done these in the past, it felt like we've sent them off into the ether, and I'm sure NHS England have kind of worked with them, but I'm not quite sure we've ever got the input. So having that link through you to the East Midlands team to actually measure progress, what I suggest, it would be really good to get some kind of yearly, 2-yearly update on how things are going? Because, you know, we've never
Yeah.
really got that in terms of how we're doing with the recommendations before.
I believe the recommendation is for an update annually to the HWBs across all three local authorities to provide an update on progress. And certainly for my role, we've never had someone leading on community pharmacy professional development locally in the NHS until I came into post. I do see my role as, you know, to take these strategic documents and then try to operationalise them within the context of obviously the National Pharmacy Contract and other bits, and to certainly work with East Midlands primary care team around the direction of commissioning, and they too are producing a strategy.
You've answered my question, Paul, because that's what I was going to talk about, was complaints and compliments part of that procedure. And actually, because of the first slide number 3 was 80-20, 80-20, so it's this, out of the 5 people, it kind of feels like there was one person that wasn't happy with the service and 4 that were, with your numbers, because that 80-20 was obviously quite set, wasn't it, in each aspect of that. But a better way of doing this is just to say what were the compliments and procedures as well. I'm not saying it's a better way, but the consultation is a good way. But because of only the limited feedback, understanding the compliments and issues that have been in the past and potential complaints in the future and how we monitor that. But really just a reflection, a really thorough piece of work, excellent in the way we can use that in our neighbourhood working and our collaborative working going forward, because pharmacy is such a key role within in community and within that broader piece of work around neighbourhood. So I think it's a really excellent piece of work going forward that we can use and work with pharmacies. Thank you.
Thank you. First of all, I thought the report was really good. I know that a couple of colleagues have already picked up the issue, but I just don't want to labour it a little bit, and you have to forgive me. We normally get a good response from Rutland on communications, consultations, questionnaires of services. So I suppose my question is almost a little bit behind that. What methods did we use to make sure it got out to the public, and how is there anything that we can learn from that? So that's number one. I just think when we're reporting back on these sorts of reports, I know the percentages are accurate in terms of the 80 and 20, but if you're reading the report and you miss that key bit about the number of respondents, it gives you a different feel for what the issues are. And when you have it's always an issue when you have a small denominator in terms of population. It's something that we come to a lot. You can have somebody who's very vocal about an issue, and it can over influence the element of the report. So, and I suppose the other thing that didn't quite come up in this report, which might actually reflect some of the positivity, we have really strong pharmacy inputs and pharmacist inputs in our PCN, and our GP practices. They have a lot of pharmacy roles, and they've developed that role as part of their Rs, which is the additional roles that are funded in primary care. And so some of the outputs of and overall needs that will come out under that needs assessment will probably reflect that we might be slightly different in Rutland than some of the other practices. So I think it'd be worth teasing that out. And my final point is around the recommendations. It would be helpful, I know you've covered one of them, when Mike asked the question, whose responsibility is it? For the recommendations, it would be good to have it clear of whose responsibility, who we are expecting to monitor each of the recommendations and undertake them, because some of them are actually quite difficult. So the access one, for example, and disabled access outside the pharmacies, it would be good to know this was raised in these 2 pharmacies because there's no disabled access whatsoever in relation to that, and they don't offer a delivery service. So it's just trying to tease out a couple of those, maybe not in the report, but in terms of how we use the recommendations and follow those recommendations up, and then the report back to Health and Wellbeing Board deciding what you want to report on. But I thought that, in terms of the content of the needs assessment, I thought it was really good. There was nothing in there that I was concerned about. I think it's just that bit about how we report to the public and to the Health and Wellbeing Board about the outputs. Thanks.
Thank you. My point actually follows on from what Deb's just said. And I probably would have kept quiet if I'd known what you were going to say. But it's particularly in terms of the digital access that we are hearing quite a few concerns about people who feel they're being pushed into using digital means for reordering repeat prescriptions and don't want to. And this has been going on through the whole of the summer. We have spoken to the practice concerned and we are monitoring it, but how are the ICB going to actually monitor people's preferences, experiences, willingness to use digital or ability to use digital? And I think this is very crucial when we've got a population, an ageing population who might for one reason or another not want to or be able to use digital reordering of prescriptions. And we also have younger people with disabilities that can't. And then there's the affordability and the signal availability. So there's a lot in there about digital access that really needs to be considered, monitored and reported back to us.
Thank you, Janet. Back to Debs.
Since your question came out of what I said, I will pick that up. I think you've raised an important point, but I want to push back on a couple of elements to it. So we talk about digital engagement in Rutland being difficult. Yet when we did our recent consultation on same-day access, the vast majority of the responses were done digitally on a phone and a tablet, and we had a really good response. So I think that there's sometimes a little bit of difference between anecdotal individual difficulties and a generalisation about the population. If we allow people access either take away digital and go back to either face-to-face or telephone access for repeat prescriptions per se, that takes up time of GP practices where we need them available for people booking appointments and medical queries. So I don't think we would want to go per se in that way. The national direction is around analogue to digital and trying to encourage people to access services in a way that maximises the overall healthcare available to the population, I think is important. However, all of that said, the issue about availability and ability to pick up digital access and order repeat prescriptions, we do need to make sure we have a facility that doesn't put anyone at risk or at a disadvantage if they can't access. One of the things in our development of Local Link and the hub will be around trying to pick up some of those digital availability issues and teaching around using the NHS app. And actually, it's one of the easiest things to do on the NHS app is to request a repeat prescription. But we will need to pick up with our practices if they are refusing to allow people to order a repeat prescription completely. And I think it's about why. It's as if somebody doesn't have access at all to any digital means, which actually is a very small amount of the population, then they need to be able to access they need to be able to order their repeat prescriptions. But I think if there are examples of that, we'd need to take that offline and I think go through the appropriate processes to deal with such complaints.
Can we come back to that, Janet?
Thank you. As Health Watch, we have to represent the voice of the public and the experiences of the public. And I understand every argument that you've made there, Deb, and I thank you for it, and I agree with what you're saying. However, there are people who over the summer months have not been able to just easily reorder their prescriptions by handing in a leaflet, by just actually handing over a leaflet or posting a leaflet to get it, and having to stand and queue for lengthy periods in one of our practices in Rutland. And I'm happy to actually talk to you about it outside. We have been monitoring it. We have spoken to the practice concerned. We know that they were taking these measures for a short period of time to try to encourage people more to move to digital. But I just think, I agree with what you're saying. Digital is easier for everybody if you've got a signal and can manage it, but we mustn't, as you say, we must not overlook those people who can't. And this needs to be monitored. And that is my concern. Who is going to monitor that?
I think it'd probably be helpful if we take it offline, because it's about what we're monitoring. I think it's important, but we'll have a chat offline.
Just to add to Deb's comments that in terms of reach and knowledge, just to be mindful, we have Living Well Rutland centres throughout Rutland, and it's an opportunity to link in with them, both in terms of digital awareness, opportunity to understand how the app works, and for reach just broadly across the county. So it's a message really just to those that are driving forward the actions, that they link in with the provisions that are there, and we can help make that happen more easily.
Janet, did you catch that with the Living Well centres? It's in this week. It's on our website. It's where the libraries are being remodelled into Living Well centres, where you can get advice, support, help, all sorts of things. There's one in Oakham, Uppingham, Ryle, and what's the fourth one? Kettering. Thank you. So read that page. Sorry, Amy, I've got one comment. It may be a correction. If you turn to page, but you don't have it in front of you, page 46, I've read the whole thing. I'd like to explain that to you, first of all. But what concerned me that the population, paragraph up from the bottom, this suggests that Rutland's population increased by 10 people between mid-2020 and mid-2023. I think it's probably more than 10. I think that may be 10%. 10%, yes, fine, but it's just 10. And I moved in there, so I'm not, and there's two of us, so there's only another 8 to go. It was just a correction. Any other comments about this paper? Right. So, any more questions, any more comments? Right. The motion of the board notes the outcome of the statutory consultation and the work undertaken to produce the Pharmaceutical Needs Assessment 2025 and approves the final PNS for publication. Am I saying that? Are we happy to approve it as is, or do we want to do any modifications? Subject to any suggested comments. So, I think, Amy, happy to make any corrections that you've heard today. That'd be right? Yeah, okay, thank you. So, all those in favour, please raise your hand.
Can I just raise a point before we have the proof? Will the monitoring of the proposal for monitoring be included in the final copy of the report? The details.
Amy, can we ask that question? Will you put in how we're going to monitor these recommendations in before it goes to final publication?
I'm not sure if that's something that needs to be included in the document itself, or whether that will be more in terms of the action plan for moving it forwards. I can have a look into that. And
Mike?
Yeah, I don't know if Paul's got a view. I see what you mean about the P&A's just going to be the P&A, isn't it? Where the action plan goes, I'm thinking we need one. Should it be circulated with the minutes? Again, I'm open to suggestion. I haven't actually got a clear view.
I really think we need an action plan, but I agree that it doesn't necessarily have to be in the P&A, because the P&A is where we are now. I'm getting some nods from some people here. We all agree, so the action plan can be separate, but it needs to address the issues we've come up with.
Bring the action plan back here.
Yes.
Yeah.
Okay, so, and can we ask Amy to...
There's either Amy or Paul. Paul, have you got a view into? I think it's probably is it a bit of a joint effort?
I think an action plan to take the recommendation was an excellent idea. In truth, it's my understanding of P&A sort of legal framework is it's probably outside of the actual document. But I think it's an excellent idea, and I think it's something that ICB should work together with local authority stakeholders on doing jointly. So perhaps we need a post P&A approval. We need to keep the steering group maybe live for one more meeting to draft and complete that action plan and agree where how it's delivered.
So we're just discussing. I think you're right, Paul. I'm aware, it's almost like Amy's done the analyst bit, so I'm trying to spare Amy getting dropped on being a policy officer as well. But I think you're right, Paul. There's a bit of a combo of a subset of people involved in the steering group that can put that together. Probably you, Adrian. I'm thinking either you or could be Mitch as well, from just to Rutlandize it and then take it from there. But if we, again, should we resolve that outside the meeting? But it needs a group first maybe to put it together.
Thank you very much for that, Mike. So, should we go back to where we were? That's right. No, I think it's very good. So we are. What we're saying is, the right page. The actual P&A, we're agreeing for that, and there will be a separate action plan and a separate group. So, if everyone's happy about the separation of those two, all those in favour would please raise your hands. Anyone against? Any abstentions? Those who should. Okay, thank you. Right, so it's resolved. We have noted the statutory consultation and the work undertaken to produce the P&A 2025, approved the final P&A for its publication, and the amendment of a separate action plan and a separate group. Right. We had a late arrival. Would you like to, hello? Like to introduce yourself? I'm going to embarrass you now in public.
Yeah, no, I deserve that. Yeah, sorry. I got caught where that train goes across the. I got caught there. So yeah, my bad. So sorry. I'm Ashley Epps, representing UHL on behalf of Simon Pizzi, who couldn't make it today. Thank you.
Welcome back. Best Start programme. We've got a verbal briefing from Kevin Quinn, who's our Interim Strategic Director of Children and Families. Kevin, over to you.
Thank you, Chair. And it will be brief because we're scheduled for the agenda in November just to give you a little bit more of a deep dive into the Best Start programme, what that looks like in Rutland. But I just wanted to raise it here today because obviously it has implications for us as a partnership in terms of working together on this. So just to note for those that don't know, the DFE announced in July the Best Start in Life programme. It's an ambitious plan around improvement of child development with an investment of £1.5 billion. We are part of that, I'm pleased to say. And there's an ambition to make sure that there's a Best Start family hub set up in every local authority across the county and there to act as one-stop shops integrating services around child development, early education, social care, etc. That won't sound too unfamiliar to Sure Start centres. At the core of it is a requirement to improve school readiness, and this is with a core focus on children achieving a good level of development nationally, and they've set themselves an ambitious target of having a good level of development in children of 75% by the end of this programme in 2028. In Rutland, we're required to develop a core offer and plan for families from conception through early years to enable us to support that goal of good level of development. There's the expectation that the services and support we provide to families and children is evidence-based. So that builds on some of the evidence-based programme and support programmes we already have on offer in Rutland, and we deliver through our family hub. But very much about early learning and development, such as speech and language, for example. We do have to ensure we identify and support children with SEND. Nothing, again, new to us and something we already do and work towards. And there is a core focus on child development and health. So again, making sure we have a robust link with midwifery, health visiting, early year settings, and we're looking at the overall health of children as well. You will know, or some of you may know, that there's the intention to replace the Red Book with a Best Start digital platform and app. So just picking up on our digitalisation. That aims to connect families with local services and will be integrated within My Children NHS app, so that's something to be aware of. But in Rutland, we're required to develop and co-produce a Best Start plan, and that includes involving families as well to meet our statutory target. Not for publication because it's still not been confirmed. We have received a statutory target for our good level of development. What I would say to you is in Rutland we are above the national average and have been for some time, and we're above our statistical neighbours. That said, we have a very ambitious target for Rutland, and it isn't 75%, it's above that, well above that. So we're in discussions about what our target is, and we'll find out confirmation of that in October. But an important point to note within that is that disadvantaged children have to benefit at least equally within that ambition around good level of development. So we're talking about children, the proportion of children who are eligible for free school meals and making sure that they achieve. So that will be a key focus for us. And our children who are eligible for free school meals, our performance on good level of development is low. So it's an opportunity for us in terms of making sure we target our programme. So Bernadette Caffrey is leading this programme of work, our head of communities, and we are working on a programme of implementation. There should be annual funding for the programme, which will align with our Living Well model. And so we await what that is. But at this moment in time, we are developing and focused on a plan to start implementation from April next year. And as I said, I'll come back in November just to talk a little bit more specifically about what that's going to look like and how that works. But I wanted to give partners the heads up, opportunity for any questions, easy questions on the programme. Thank you.
I've got a few actually. Sorry. Who sets the targets as a matter of interest?
The DFE. And we've been given an opportunity to go back on our targets if we are concerned that it's not accurate, but there's little room for manoeuvre on it. It's a 9% uplift.
The development. I'm going to ask Janet's question probably. Dental, which is one of our favourite topics. Will that be part of the assessment and development?
No, the assessments around education and preparedness for education when you enter reception. However, tooth decay is part of our programme, and the Best Start programme is about joining up services at an early stage and making sure we tackle all aspects. So tooth decay is paramount to that, and as you're already aware, our Children's Centre, our family hubs are supporting that as it is.
Okay, number 10 is neighbourhood health update. Now, we've received apologies from Sammy Lacour, who's the Health and Care Collaboration Project Manager, but we have had a written update, a copy of the last highlighted report that went to the ICB's Neighbourhood Health Programme Board. And Sammy has said in her appendix that she can be contacted if you have any questions. If anyone can help me, I would be very grateful for some interpretation of the abbreviations. So if anyone knows, let me just tell you what I don't know. I've read this carefully. CJM. It's the local link integrated front door. CJM? So on this page at the back,
Fran's going to answer.
oh,
I have the answer, Chair. So it's customer journey mapping.
So I think your question is quite pertinent, because the highlight report, which is at the back of this report, is an internal ICB report, and I think when we are sharing, and I'll chat through it with Sam, and when we're sharing things to the public, we do need to have a key, so we will make sure that we put that through. I think given that there's been an awful lot of work and development around neighbourhood health, and particularly with Rutland, with your agreement, Chair, we will have a bigger agenda item at the next board, and Sammy to come and do a presentation. And if board members want a written update on a regular basis, then we will make sure that it's public facing. Thank you.
that. Sorry, Janet, it looks like she wants.
If somebody could tell me what fit out and LUF is, then I would be very grateful.
LUF is Levelling Up Fund, which is funding the building developments in around Rutland Memorial and around there. And I think fit out, I might be wrong here, is when you're actually getting Jules' house ready and it's being fitted out. It's as simple as that. So it's being made fit for purpose for the use it's going to take, and it's going to be the front door. And I think we probably bring Kim in there.
The only thing I was going to pick you up on is local link. So that property that we now name local link, not Jules' house, just for clarity of the community who might be listening in. And I took that fit out as what does that building look like when it's occupied, but we're still working through that.
So Chair and Jane, if okay, what I will suggest is that we resubmit this report with the minutes, but with a key and some sort of definition, so that the public has the opportunity to have those explanations. Thank you.
Thank you very much. To item number 11, Leicester, Leicestershire and Rutland Integrated Care System Update. We now have report number 90/2025 from Pete Burnett, who is the new Chief Officer for Strategy and Planning at the LLR Integrated Care Board. Pete, over to you.
Thank you, Chair. So, yeah, nice to be here. I'm sorry I couldn't make the first meeting when I was in post, but I'll make sure I try and make it every other one, unless I'm on holiday. So, no, it is good to be here. So I'll give you an update on where we are in terms of the changes to integrated care boards and what that means for LLR, and how that will kind of progress going forward. So I'm sure you know, but back in March, April time this year, the government announced changes to the NHS structure that included NHS England being merged with Department of Health and actually being taken over by the Department of Health going forward. It had changes to providers in terms of having to reduce their corporate back office staff, and in terms of ICBs, a circa 50% reduction in its running and programme costs. And then, so that was announced back in March, and then following that there was a publication of a blueprint for ICBs detailing the future roles of ICBs and what they were going to be and what our targets were in that sense. And the target in that respect initially was slightly lower, but it's now £19 a head per population we serve. That's how much money we have to run the organisation. So ICBs up and down the country then looking at how kind of they move to this blueprint, model ICB blueprint, and that sets out ICBs as strategic commissioners, looking at outcomes and population outcomes and commissioning on that basis, and ensuring value for money from the contracts we carry through, making sure there's a payer and we're paying the right amount of money for a service, not disproportionately too high in that respect. There's work to be done in that, and there's still national documents coming out around strategic commission that haven't yet been published, and programme plans for kind of that development at the same time. But ICBs were then, so from April into May, looking at how they can actually reduce their programme running cost to this £19 per head, while also maintaining they can deliver what was required in the model IC blueprint. And that included, blueprint says the functions the ICB is going to have, so strategic commissioning and those elements, and also functions that the Department of Health determined should be kind of passed on to other organisations. So safeguard and send, emergency preparedness would move elsewhere, continuing healthcare potentially would move out where when that document was published at the time. To do that, depending on the size of the ICB, some ICBs looked at, well, how do we maintain, how do we kind of get bigger, get economies of scale to enable us to deliver the functions we need to deliver in an effective way without making the cuts too harsh. Some ICBs were big enough anyway, so up and down the country ICBs looked at what their kind of configuration might be in that respect. In terms of LLR, we looked at our colleagues in Northamptonshire ICB and agreed a process of looking to cluster as an ICB. And to be clear on the clustering isn't a formal merger, and the reason some ICBs are looking to merge this coming April, but we're not looking to do that because the local authority kind of reorganisation needs to play out, and then ICB footprints need to kind of align. They can cross two, but they shouldn't cut in half a local authority, a mayoral footprint, for example. So if for example Northampton went with Bedfordshire, you couldn't have two ICBs operating in that footprint. So as a cluster, it allows us some flexibility when that kind of decision making takes place. So that's what we're looking to do. That enables us to kind of aim to deliver the functions as outlined in the blueprint, but while also maintaining the critical mass to enable us to do that. Thankfully, there was a 50% reduction identified nationally. For LLR, that worked out to about 32% actually, because the running costs and programme costs were lower, and in Northampton that was 29%. So actually we want the lower end in terms of savings having to be made compared to other organisations. So we worked on that, we looked at what our functions are, and how we're going to move forward. There's been a process to appoint a chair of the cluster. That was announced last week. Anu Singh, who was the Black Country ICB chair, they start in post on the 1st of October. Paula Clark, who's the LLR ICB chair and interim chair over Northampton, will finish in post on the 30th of September. There's also been a process to appoint a chief executive. Currently, Toby Sanders, who's the chief executive in Northampton, is the interim chief exec in LLR. There hasn't been any formal announcements on who that chief exec is, but it has been published in terms of HSJ who they believe their chief execs are. I'll leave it as that at this stage, but it requires a national announcement in terms of formal appointments into those roles. Following those appointments, though, the current process that NHS England required organisations to do is to look at their executive structure. So across LLR and Northants, the executive management team are going through a management change process at the moment in time. So there will be a reduction in the number of execs. So currently, each organisation has 10 executives across both organisations. That's going to reduce to 5. So there is a management change process taking place at the moment in time. By October, it's certainly run its first phase. It doesn't guarantee anyone necessarily to get a role, but that's why I say it will run its first phase. So the people who have applied for certain roles will be kind of go through that process to see if they're appointed and that kind of piece. Moving on from that, the next stage is bringing the boards together. So in this month, LLR's board development session and Northampton's will look at the future governance arrangements across both organisations. The aim is to have a board in common, so they're both boards meet at the same time, and then a governance structure that works out across both organisations in a kind of streamlined way. The issue we have is to hit the £19 a head. The initial announcement was to do that by December. In our financial plans, we didn't, and we're not like standalone. This is noted across ICBs up and down the country. There wasn't provision for the redundancy that would take to make that happen, and there isn't the provision in our plans to make that happen. So currently, all ICBs are a bit of a kind of no man's land to some extent, because we can't enact those changes. So we can't go out to look at a management of change, what that future structure might look like at this moment in time, because we haven't got the fundings to deliver the kind of reduction in staffing that we need to do. And you can't, because of accountancy practice, you can't even announce an intent to do that next year, because you have to accrue the funding as soon as you make that announcement. So that's where we are at the moment in time. There are debates taking place at national level with anything in the department. We just need to see how they plan out, or how they map out going forward, really. Which does leave our staff in a position where we'll have an exec team who might do the layer below the exec level, but we'll have this disjointed arrangement for the time being. Clearly, there's a lot of work going to how do we work as collective as we can, and we'll have a bigger critical mass. So it's not all Paul. We keep all our staff at this moment in time, but it does cause them an issue in that respect. Other bits that have come out since that, so some functions are being reviewed. So some functions like SEND, safeguarding, CHC we're looking to move elsewhere. Emergency preparedness, that is now under review again, because I think the feedback has said I'm not sure that's the right thing to do. So that's under review. And yesterday NHS England published the model region. So as NHS kind of moves into the Department of Health, they have to look at the national structure, what happens at a national level, what happens at a regional level. That was published yesterday to give us some guidance. So that's where we are currently. Happy to take any questions from anyone.
Thanks, Pete, and welcome to Health and Wellbeing Board in Rutland. Nice to have you here. The model blueprint that came out, that was rapidly put together at the beginning of the year, and then as you're talking about the practicalities of how you enact a lot of this work, one of the things that you talked about is review to transfer over. And as a Director of Adult Social Care, the CHC and the safeguarding aspect, can you tell us anything more about what those discussions are happening at the moment, and how we're going to be consulted as councils within that transfer over? Because where is it going, and how are we going to be included in that discussion? Would be really interesting, because to date I have not been included in anything.
So I think those discussions currently, the review is taking place at a national level. It isn't done locally at ICB. So nationally they're looking to see, okay, where is the best place to move these functions to. As soon as we get into a position where actually we've got an identification of are they staying with us or are they moving, clearly we need to engage with our provider colleagues and who are aware of that function will move to see how that would happen. Because the other challenge with it is we have to also reduce the staff. So that is the totality of our current staff has to reduce down to that £19. So it's not like you can take a whole service and move it across and that makes you saving. You have to make the saving beforehand currently as it's written. So we need to see how that works out.
And I'm presuming it's going to be legislation changes as well, which again won't make it a quick process to happen because of the currently in legislation at the moment. So that would have to change if you want transfers over.
Yes, so they're looking. So when they announced the 10-year plan for NHS, they also identified areas like the Commission Support Unit that support ICBs will no longer exist. The intention that health watchers would no longer exist, and the intentions in terms of integrated care partnerships, for example, wouldn't exist, and other changes that has to go through legislation in the first place. Expectations that's happen within the next 12 months. So most expectations not confirmed, changes will potentially happen from April 2027, but that's obviously depending on the legislative pathway of this through Parliament.
It's just to add to Kim's point, and Pete's already covered it off really, but obviously concern around in the blueprint around safeguarding and SEND and understanding what that actually means at a locality level. And I know, speaking to other colleagues, there's a lot of nervousness that we've not been involved or engaged in that, so we're keen to be involved and engage in that and understand what it means, because I'm not sure you can forgo your safeguarding duties. So I'm trying to understand what that actually means at a local level.
I think we're very aware of that, and I do go to the ICB meeting, so very aware. But yeah, I think we need to be. It was surprised me how quick it was delegated down to local authority, but then removed. So, as Pete says, we will have to wait and see. And I don't envy you because it's all very much up in the air now. Everything, it would appear. It's not. Right, Janet.
Yeah,
Yes, I'm the chair of Health Watch Rutland. I just would like to know where the public and patient voice is going to sit within the governance of the ICB, if possible, please, because there's been no clarity other than the ICBs are going to do it once Health Watch has stopped.
So I can't say that what the government's intent is around the role of but the role of Health Watch in terms of where they see that function being done, because in the original blueprint it also talks about actually engagement wouldn't stay with the ICB, it would go to local authorities as well. That seems to have changed. So we'll continue to have our engagement teams that we look to work with the public and inform our kind of strategic plans. I can't, it's not a decision the ICB's taken around Health Watch. I have a personal view on that in terms of an independent voice of the public that can get brought in. Some of this will depend on how the legislation goes through Parliament and what if they identify that another service will take that on from an independent area really. So we don't know at the moment in time.
And sorry, Pete, just to go over that again. So the functions that were going to be spun out to the from the ICB aren't. So take EPRR maybe as a better example than safeguarding. Is that still under review then, or is it definitely going to stay within ICB? I've confused myself now about whether it's kind of just a further, we'll think about it and let you know whether they've definitely kind of pulled it back into ICB world.
So they're reviewing it, as I understand. So, and the model region that came out yesterday, the document on the model region, which I don't think has been published but has been circulated to certain colleagues within the NHS, doesn't it doesn't confirm one way or the other. So the model ICB said these functions will move over the course of time. The model region doesn't say that. I think for EPRR, for example, there's an acknowledgement that how do you do that on, well, there's a potential acknowledgement that how you do that on a regional footprint if you're having floods and severe weather and suddenly there's floods in LLR, across LLR, there's floods in Lincoln, how a regional team that's also reducing by 50% is going to pick that up and have that local input with the LRFs and all the rest of it. I'm not entirely sure how that's going to work. So that's why it's been reviewed, but we don't know what the review's saying at the moment in time in terms of where they've determined it. There's a view from us where that actually what would happen, but we have to wait and see what gets agreed in the long run.
So the model region's modelling before it knows exactly what it's modelling. Got it.
If I was being very cynical, which I couldn't possibly, it does seem it was a great idea at the time but not thought through very well, and they're now thinking it through. And I think particularly the redundancy, the lack of funding for that's my big concern. And I think everything is going to come to a complete halt. Can I just clarify something though, Pete? And I did try and scribble it down. Northampton was 29% as compared to LLR, which was a lot lower. Higher, sorry, that's the bit I missed.
33% for LLR.
33.
Which is still lower than the national average in terms of the saving, which I think, well, it said 50% when they announced it, but it's about 46%, so it is still, and if you look at when they did the chart on it, we're both organisations are down the lower end in terms of savings they have to make.
That makes it more achievable in a way, they're closer. Thank you, just for clarifying.
Yeah, no, the only other point I'd make, I think the benefit of our cluster, there is some synergies because our provider colleagues, both in the acute sector and the community and mental health sector, work already in a collaboration which helps across border, and that's helpful to some extent. Doesn't everything, because obviously general practice, but we'll also carry on. We haven't worked through all this because we're still appointing the exec team, and then we'll work through the kind of structure in the long run. But our place-based and then work will continue as it is. Obviously, we've got a reduced team, so we'll have to look at exactly what we can do. But I think for a cluster, there is more synergy. I came from the Lincolnshire ICP previous to this role, been there for 5 years, and they're linking with Notts and Derby, where there isn't quite the same synergy that we have in terms of provider kind of networks in our area. There are links because there is tertiary pathways into kind of major cancer centres and that kind of piece, but for us, I think it's not just, we're coming together because it's convenient. There is actually a logic to it at the same time.
What am I up to? Oops. Yeah, so thank you very much. So we've thank you for that update, Pete. And I think we've noted what you've said. We look forward to hearing developments it goes along. We have to note the contents of a report. Now, there is a report in your pack, so hopefully you've all had a chance to read through that. And we've heard from Pete. So I think we can accept that. And all those in favour of noting the content, please raise your hand. Note the contents of. No, it's note the contents. We're not approving anything here. Anyone against? Any abstentions? No, thank you. So we resolve that we've noted the contents, and that's it for item number 11. So moving on to item 12, the Joint Strategic Needs Assessment updates and timelines. We now have there he is, a verbal update from Adrian Allen, Assistant Director, Delivery, Public Health. Adrian, over to you. Thank you.
Thanks, Chair. There isn't a huge amount to update on in terms of where we're at with the JSNA. A lot of the resource recently has been pulled into producing the PNO. What I would say is that the meeting that was held on the 1st of April of the Health and Wellbeing Board approved a new way of delivering the JSNA programme, and we're still working in the background to look at priorities. So there's a number of working groups that are being pulled together to look at what priorities are needed, I guess, over the next 12 months. So hopefully by the next meeting we'll be able to bring a bit more of a detailed forward plan for that JSNA programme. The one thing that has been updated though for colleagues is the Rutland profile. So that's bang up to date now in terms of the...
Hang on, Adrian, sorry, can I interrupt you? What was that? I missed that word then.
It's the Rutland profile.
Oh, thank you.
Yeah, it's the demographic information for Rutland. It's the one thing that most people use to be able to identify the makeup of Rutland. So that has been updated. I'll send the link to that to Jane to add into the minutes. But that's it for the update, Chair. Thank you.
Thank you for that, Adrian. So I'm handing over to Mike now.
Just a quick one for me, Adrian, the health profile, does that need to come to board to, like in the old days we used to call them chapters, I guess we would have signed off each chapter. Do we have to approve that, or are we just going to publish it, or do you want to take comments? I'm grateful the work's been done, we got through the PNA, we'll now do the JSNA. Just want to get into a routine of where the board stands around the content that we're developing.
So the profile doesn't normally come back to Health and Wellbeing Board. That's a constant update during the course of the year when new data sets are released. That's a live process, I guess. As part of the new JSNA strategy, that will work in a similar way. So there'll be a dashboard process rather than individual chapters. We need to work out how we bring that updated dashboards to the Health and Wellbeing Board and at what points we need to do that for authorisation. So that's the piece of work that's happening in the background now.
Thank you, that makes perfect sense. Does anyone else want to clarify what Adrian's just been talking about? Are we all happy about that? Okay, so lots of work for you to do, Adrian. You're going to have till tomorrow.
Thanks very much, Chair.
Thank you, Adrian. No other comments? No. No questions, no comments. We'll move on to the next agenda item. And we've lost Adrian, which is fine. We are now on to item number 13, the Joint Health and Wellbeing Strategy. It's a verbal update from Francis Hinton, Health and Integration Lead, Rutland County Council, regarding the Joint Health and Wellbeing Strategy. But I first of all must give you congratulations for your recent wedding and but you're staying with Hinton. Okay, thank you very much.
Thank you, Chair. Thank you for the congratulations. So yeah, just a relatively brief update around the Joint Health and Wellbeing Strategy, because I brought the new refreshed delivery plan, obviously to the last board meeting, which seemed to go down well, which was fantastic, but there were a few areas that we noted that needed some work on, particularly around priority 3, which is the healthy ageing and living well with long-term conditions. So a couple of meetings have been had, and we are now very close to completing that. It's been discussed, and it will be brought to the board in November, but we are looking at having 2 completely new objectives under priority 3. One will reflect unpaid carers, so the identification and support for unpaid carers across Rutland. This obviously links in very well with the strategy itself, and also with the work that's going on with the Better Care Fund and the objectives that we're delivering across Rutland with that. And also a new objective to reflect the operational working being done by the PCN, so the Primary Care Network, and also our RISE team, so around proactive prevention and also the co-location and joint working and integrated working that's happening between those 2 teams. So what I am going to do is bring to the November board meeting a mid-year delivery report, so that will show the board kind of a summary, although I know you love reading my spreadsheets. It will give a summary of our delivery so far for the last 6 months. And then I will bring the finalised, for your approval, obviously, the finalised delivery plan itself as well. So that is about it for the strategy. Any questions?
Yes, I have a question, of course. These 2 additionals for priority 3, the unpaid carers and PCN and RISE, are they local to us, or are they? So we've chosen to add them in because they meet what we're doing and what we want.
Absolutely, yeah. So this was following a discussion. The working, as you know, around the delivery plan has been completely joint between health, social care, and the voluntary community sector. So yeah, this is completely Rutland specific. So it links in with what we're delivering for our residents and our internal teams as well. So this will reflect our carers team and what they're doing across the county.
Thank you. Show the personalisation of it. Thank you.
It's not a question so much as an observation that I've been making over the years in this role, and that is that, yeah, you've got unpaid carers that are looking after physically or mentally quite established disabled people, but there are people that are slipping slowly into the carer role, and there's no definition of when you're actually delivering a bit of care to when you become an unpaid carer, a sort of able to register as a carer and that sort of thing. And then in that journey, there's times when people are caring a lot for somebody, but then there are times when perhaps the condition's a bit improved and there's not so much care needed. So I feel there needs to be more definition about what unpaid carer actually is, if that is possible, please.
Yeah, no, absolutely. And hidden carers, which is exactly what you've touched on, Janet, is something that we're really keen in Rutland to do. And there is no kind of one same caring journey. Every carer's, so unpaid carer's experience and journey is different. And we may, as professionals, we may recognise things that an unpaid carer may not realise, and they can stay a hidden carer for quite a long time. And also we found that, and you can probably tell that I used to work for the carers team many moons ago, so we find that one carer's level of resilience, let's say, can differ greatly to somebody else's. So one caring role for someone, and what they can manage, it is very personal to that person. So the carers team with Libby, our carers lead, that hidden element of caring, and as you say, when we have a wonderful generation, particularly in Rutland, where it's very much, I don't want to kind of, take anything, off the government. I don't want to start kind of claiming, attendance allowance or, anything like that. No, I can manage, where actually, so we need to be very holistic about it and very personalised. So this is why we wanted to put a specific priority, a specific objective into priority 3 that is dedicated to unpaid carers and that caring journey, because it's huge and quite complex. So yeah, we're highlighting that, I suppose.
Yeah, just to give extra information for anyone that might be interested in listening. If you go onto Rutland County Council website, there is a page for carers to understand and have advice and information about if you are a carer and where to contact about the support that you would get to help your own well-being within that service. So and we have in Rutland, we have dedicated carers team and an admiral nurse carers team as well. So we have a good resource to support carers. So I would ask people, if they are a carer of any sort, or not to overcomplicate it, go to the website, take some information about where you can get advice and information, and it is out there in Rutland for you to receive that, and you'll get the right information and advice about how your particular experience and support can be provided in Rutland.
Any other questions for Fran? No. Moving on to the next agenda item, the Better Care Fund. We now have the Q1 BCF report from Fran Hinton, Health and Integration Lead, Rutland County Council. Frances, would you like to present the report to the board, please?
Thank you, Chair. So the Q1 report, as always, is slightly shorter than the other quarterly reports that we do. So for Q1, there was the focus on expenditure, as there always is, and then there was just a recap of the metrics, so the 4 metrics that we're going to be delivering on this year. So the only thing to note to the board, which was highlighted in the report that you've received, were just 3 small changes to the metric, which is avoidable admissions. So that's the first metric within that report on the metrics tab. And the changes were purely to reflect and mitigate against the winter pressures that we face. So the changes were for December 2025, for February 2026 and March 2026. So when we did the end of year report that again was shared with the board a little while ago, not all of the data was available to us because of the timing of producing that report. So through hard work, we've managed to access quite a lot more of the data, and we have, for the Q1 report, we have all of the data available, and this is the 2024 data. So the changes, again, it's in the report, but just to go through. So for December 2025, so we had planned for 140 avoidable admissions. However, in December 2024, our total avoidable admissions, it totaled at 145. So we were ever so slightly out. And the wonderful thing to remember is that in Rutland, because we are dealing with a smaller population, these numbers, so our 145, for example, we can directly link these to people. You know, we've got those that privilege. So we've amended and the national team allowed us to do this through the Q1 report, and this was nationally. Everybody had the opportunity to do it. So we amended our December 2025 avoidable admissions slightly to 141 as opposed to 140. So then we were looking at the February 2025 data that has now come through. So that was slightly different. So we had planned and I'm hopping all over the place with dates, so you'll have to have the report in front of you. But for February 2026, we'd planned for 135 admissions. However, in February this year, our total admissions was 130. So again, we have changed that. So our new planned total is 130, just to reflect that. And then for March 2026, we had planned for 135. However, our March data, which we've now got access to for this year, our avoidable admissions was a lot higher at 155. So we've mitigated that, and we've put our new plans admissions for March 2026 to 150. And the aim of this is just to improve our performance on a month-by-month basis, as opposed to only looking at the overall. And that's really just me being a bit pernickety, to be honest. It's great to say, overall, we have met our target for the year. But actually, if we break it down, because we're dealing with smaller numbers in Rutland, it's great to break it down monthly and say, actually, you know, we performed or we underperformed by this much. So it's all there within the report that I've shared with you, and more than happy to answer any questions if anyone's found that potentially complex. I don't know whether I explained it very well.
Actually, you explained it, I thought, very, very well. And it's given me a far clearer picture about it, because it's one of the questions that I'd asked you before we came into this meeting, about clarity of why are we changing metrics and doing differently, and you've given a very good account, so I'm assured by that. Thank you.
Yeah, go on. Thanks, Fran. Out of interest, I know it's only monthly figures and it's small and it can go up and down, but I suppose a bit of me is now looking at the monthly figures going, how come either with a plan or for actuals we get more in March than we do in January? And why do we get more in September than we do in January or February? It's kind of just eyeballing the figures thinking, I wouldn't have expected that to be a peak month.
And that's exactly what I thought. So I've jumped on board with the winter planning and pressures kind of cohort for LLR, because I want to understand why we saw, kind of variations in September. It seems a little bit kind of off. And obviously, you know, seasonal changes, you know, okay, you could associate some seasonal changes possibly with September admissions, children going back to school, universities starting again. So there are two prongs to it. So my work with the national BCF team around Rutland specific data, as you know, is ongoing. To be fair, their response and work that they've put in for our data has been very good now. I think we've reached an understanding, which is great. What I'm yet to kind of receive, so I've now got access to these huge piles of data, which is fantastic. But for me, and as the board will know, I like the rationale behind that data. So it's all well and good bringing you numbers. I want to be able to tell you why those numbers are what they are. So there may be an element of a bit of a guessing game, but as I said earlier, because we are able to put these numbers, obviously there's, you know, patient confidentiality involved with this and GDPR, but because we have such an in-depth understanding of people that are known to us that are going into hospital, with working with a hospital team, we can get a better idea of it. So it's I suppose it's going to be a case of, we'll do Q2, we'll see whether we experience the spikes again, and then we'll try and find some themes and trends possibly from the data, if that answers your question.
Yeah, no, I think it'd be fascinating, as you're saying. I mean, you know, you're right, there are probably ways of explaining September on the back of kind of staff absence and stuff. The March one's interesting, and again, it's worthwhile just chucking out hypothesis. It's counterintuitive, but part of me is this almost, you know, it's emergency admissions, but to what point people hang on and don't want to bother the NHS at a really busy time, and they get to March and then go, actually, I really need to be admitted. So there's all kind of human behavioural shift pattern stuff that might be at work there. It should be. And you're right, we have a chance of looking at that kind of case review in Rutland because the numbers are small enough to dive into it.
Absolutely, and I'm now working with urgent and emergency care across LLR, and we are looking, so I've had meetings where we're now looking to bring in, so Peterborough and Cambridge, so obviously Peterborough City Hospital, so the urgent emergency care guys over there as well, just to have a better understanding of those themes and trends. But it was really interesting having a conversation with one of the senior bods from the urgent emergency care team for LLR, and we were actually talking about exactly that people are reluctant to go into hospital at peak, what they view as peak times of the year, for fear of actually going in and then potentially getting worse or getting stuck within hospital and not being able to come home. So it would be very interesting as well, I think, to explore the public's perception of, you know, kind of, yeah, what do you feel about access to those urgent and acute settings at times of year where even in you know, the national news, the kind of the local news, these winter pressures, these winter surges, you know, the media has a tendency to use quite extreme language around it, and I think it can be quite frightening for people. So yeah, it's ongoing. I'm in with the right people now, so hopefully we'll get some answers.
Yeah, it's really interesting, Fran, to sort of see these peaks, and I'm just wondering if there's any link with the waning immunity to COVID in this age group. In September, the spring vaccine will have been waning, and then in March, the autumn vaccine will have been waning. And I'm just wondering if there's any correlation with COVID at that point, and this age group are much more susceptible to the COVID illness itself. So I just wondered, this hypothesis.
Yeah, no, absolutely. And I think it's the same with flu. And I also think, although we're running winter vaccination programmes with providers and obviously our pharmacies as staff, you know, of Rutland County Council, we're offered winter vaccinations. I think that there has been a lull in people's urgency around it as well. And I think that that's probably a contributing factor too. You know, although certain kind of people will still continue to get vaccinated yearly, I think for the general population that the importance has been reduced, the necessity's been reduced. Therefore, there are more bugs floating around. And I think certainly with back to school and back to university in particular, those kind of clusters of potentially less vaccinated, shall we say, people, it's all contributing. But yeah, I think COVID definitely still plays a part.
So I think it's an interesting conversation, and I can understand why it makes us think, you know, could it be this, could it be that? I just want to remind everyone, these are very small numbers, and whilst I absolutely agree with why we've reprofiled the target this year to be influenced by the actuals of the previous year, our population is small, and these small variations can just be purely fluke. So I think it is influenced obviously by number of days in the month, it's influenced by post-holiday periods, influenced by sort of outbreaks of flu, RSV, or a host of things. It can also be influenced by availability of ambulances, availability of doctors. It can be influenced by a whole host of factors. And I think that we're probably procrastinating a little bit too much for such a small number at this stage. I think if we see big variations in the future only in certain months, then I think it's worth us doing a bit more digging about. I think what we need to concentrate on is those individuals. As Francis, we're lucky in the one sense, we've got very good integrated teams, we've got some excellent neighbourhood working developing, and we can identify those individuals because it's small numbers. So it's what can we do for those individuals which will help in terms of planning, care planning, help influence or reduce their necessity for an emergency admission. So I think I'd prefer us to concentrate on that element rather than us analysing the data about why we might be different from, in 1 month or another. I think the two things but by concentrating on reducing emergency admissions by the proactive work we can do, I think we'll probably pick up some of those other factors anyway. Thanks.
Just going to come in a little bit with that. Absolutely agree. What I would say is that because we're dealing with smaller numbers, just a variation of 1 or 2 people can really change our outcomes. So although we're getting down to the really nitty gritty, I think when it comes to the BCF, because the numbers that we are the numbers that we're provided with, because we're dealing, there's a calculation that has to happen per 100,000, and obviously we're getting to the bottom of that. A lot of work's gone on around understanding the data specifically for Rutland. So yeah, we tend to find that those small numbers can really kind of throw us out, and it could be luckily the 24, 25 and what we've planned for with 25, 26, they're still incredibly ambitious. These changes will continue to be, continue on our ambitious journey, and we are looking for a reduction of 115 admissions over the course of the year. So it doesn't sound a lot, but it could only take 5 either way, five admissions either way, for us to then not meet that target. So it's been a really interesting process with the data and how finite it can be for Rutland.
If I could just make one final point, and I absolutely agree with that element, but just mainly for members of the public, our focus on emergency admissions is to not stopping people going into hospital if they need to go into hospital. If patients and our public need an emergency admission, we need them to have access to hospital care. Our purpose is to stop unnecessary emergency admissions. So if we can do some more proactive work, which will enable somebody to be cared for at home in the right place, or to prevent their condition deteriorating, and that's what our focus will be. And that's why I talked about the neighbourhood working and the way we do health prevention. An emergency admission is sometimes needed, and if it is needed, we need to make sure that people have access to that care. Thanks.
So, no more questions, so we'll move on to the next agenda item, number 15, review of the forward plan and annual work plan. So this, it's included in the agenda pack. Any items that we've missed out or we think should be included in that? Let me just find my page. So this is agenda item 15, and I've got Debs next to me.
So I think we've talked about the need for a neighbourhood update. The agenda for November is very full, but I've been looked through it. I don't think there's anything really that we can necessarily pull from that agenda. I think we obviously just need to all be focused when we go through it. But the neighbourhood health thing, I think, is really important to have that update. And I was going to raise it when we were talking about the health and wellbeing strategy and update. At some point, Fran, I think we need to consider, so we're over halfway through, or just over halfway through our strategy and our action plan based on that. But any strategy and action plan is as good is good for the day you write it, and obviously the world changes, and we've had quite a lot of changes in both health, social care, the direction of travel more recently. We've got the 10-year plan coming up. We've got some changes, structural changes going on. And we've also got some big changes in our population, which we're picking up through health and social care needs assessment. And I suppose what I'm going to, at some point, we need to consider, Chair, about when we do, and I don't know, might have a view of this, when we do and refresh our work plan, because in theory, all the good work that we're doing on neighbourhood health should come into our health and wellbeing strategy and action plan, but actually at the minute it sits aside because it's but that's one example of a development. So we might need to consider in maybe the January or the March boards about where we go next with our planning, and are we still reporting and working on the right things given the current and known future developments of health and social care and the needs of our population that are coming out of the JSNAs.
I think you've done everyone to silence there, haven't you? So any other comments about the forward plan? Anything else, Mike?
Just to check with Deb, so in terms of what would you want then? So there's that kind of reflection on the demographic data, if you like, which I'm, happy to take that forward. I mean, I'm thinking even if the agenda's a bit heavy, we could always find a way. We could task Adrian and Mitch with just thinking about how do we put together something to come to board if we think there's something in there. It's like actually we need to be thinking about the changes in the population now. And then there's the bit about kind of neighbourhood, well, not neighbourhood, more changes in the NHS, which we get onto the bit about how it affects Rutland, and the two kind of go together in my mind. Are you thinking a bit of both more urgently?
I think probably November's is fine. I don't think we necessarily need to do what I've described in November, but certainly the first quarter of next financial year, I don't think we want to be continuing ticking boxes about reporting on things just because they were in our strategy 4 or 5 years ago, if they're not reflecting what the work that we now need to be doing. So I just personally think we need to start, as a board, start spending some time thinking, so where do we want to be going in the next 5 to 10 years?
I would suggest a critical refreshment and perhaps a change of plan. As you say, depending on what's happening and changes happening everywhere in healthcare, not just here. So, is that right, Jane? Do you know what you're going to put in there? Good, thank you. I'm loud enough. We have actually distributed the winter plan from the LLR ICB, and it's for information only, but it is attached to your attached to your agenda pack, and it is the executive summary, which was I can't remember who found it. Was it you that found it? All right. It was all right, yeah. And I think that's worth looking at as to what's happening within the LLR health and care system. Deb.
So just for board members and members of the public's perspective, what we normally do, and it's not just Rutland, is that scrutiny committees have reports on the winter plan, and that's where the fuller discussion happens. So I think it's scheduled for the next scrutiny committee. End of September. But I wanted it to come to the Health and Wellbeing Board so that the members were cited, because I personally think that if something is going to scrutiny, it's a regular report item, that we should have sight of it. So, I mean, we didn't necessarily want it for discussion unless people wanted to raise it, because the way in which we look at the winter plans. It's normally through scrutiny committee, and it is already scheduled. If that helps, Chair.
Any other comments about the winter plan or any other urgent business? No. Right. Okay, let's declare this meeting finished.
Date of the next meeting.
Date of the next meeting, thank you, is the 18th of November 2025, 2 p.m. And I declare this meeting closed at 3:43 or something like that. Yeah. Right. Thank you very much to everybody.